Okay, can we begin next part? Great. Okay, so I would like to welcome everyone on. Can you hear me? Okay, great. I would like to welcome everyone on in the panel about long COVID. Let me introduce my guest. Our guest, David Steadson, epidemiologist living in Sweden. And there is with us online Vicky van der Togt from Long COVID SOS and Research Aid Development. We have theoretically 45 minutes. We must not prolong it. We will try to keep it shorter. Okay, and my introduction will be simple as well. We have 20 minutes for David to speak about nature of long COVID, about its scale, about its consequences, and means to mitigate, to prevent sickness. And Vicky van der Togt, after that, will talk about long COVID communities. We'll talk about her victory in Netherlands court. It's something very important for the context of well-being in workplace, and meeting and with team of Commissioner of Jobs, Nicolas Schmid. Okay, so let's begin. David, the floor is yours.
Great, thank you very much, Alex. I wasn't sure how long my talk was going to be today, and I was actually up at 5 o'clock this morning finishing it, so apologies for any typos and other errors. Today is actually International Long COVID Awareness Day, by coincidence, March 15th every year. So on social media, you'll see quite a lot of activity about it. If you're wondering about my accent, by the way, I live in Sweden, but I'm Australian, so that's where that comes from. Now, this is a statement made by Dr. Elise Perago back in 2020, and we have lost the slides. It's back. The potential personal, economic, and social costs of long COVID are unfathomable. Unfathomable. That was said back in 2020. Why was it said back in 2020? Well, Elise was actually the person who coined the term long COVID after it became apparent that there were people not getting better after COVID. This shouldn't have been a surprise. 10 years after the SARS epidemic in Hong Kong, and it also spread to Europe, half of the people, the healthcare workers that had SARS, could not return to work. They were still ill with all of the same types of symptoms we're seeing today with long COVID. So the problem appeared very early in the pandemic. Now, what is it? You'll often hear, well, we don't know what it is, there's no agreed definition. World Health Organization actually came out with an agreed definition 2.5 years ago. It's basically, you've had a probable or likely SARS-2 infection, and you're still sick for at least 3 months, and then 2 months more after that, and you're not getting better. But what symptoms can it be? This is the problem. And there was talk in the earlier panels about the issue of different specialists in healthcare. Long COVID affects different people in different ways because this virus is not a respiratory virus. It's a virus that can get into every organ in the body, including, perhaps most importantly, the blood vessels, which means it can then easily spread everywhere else. So you can see on this graph here, we have it causing increases in diabetes, autoimmune problems. An issue called POTS is very, very common in long COVID patients, post-orthostatic tachycardia syndrome. Basically, their body is not able to control their heart rate and blood pressure. Blood clots, strokes, erectile dysfunction, decreases in female fertility, brain fog, fatigue, sleep problems, food problems. You name it, this virus can cause almost anything. The most common issues that most people notice are extreme fatigue and breathing problems. And it's not just fatigue where you feel a bit tired, and I'll come back to that a bit later. But what causes it? Well, leading theories over the last few years have been it's some kind of autoimmune disorder, and it's probably related to myoencephalitis, so chronic fatigue syndrome. Blood clotting has been clearly demonstrated, particularly a thing called microclots. Normal tests don't show this, that actually are clogging the capillaries in your body so that the blood is not circulating properly through your body, and so oxygen can't get where it's supposed to be, whether this is your liver or your fingertips. So a lot of people with long COVID, you can actually see in their fingers and toes that the blood is not getting there. And the final one, which seems to probably be the root cause of the majority of long COVID, is viral persistence. We're not properly clearing this virus out of our body. Now today the only question is, does this happen to only some people, or does this happen to nearly everybody? And the evidence is starting to lean towards nearly everybody that has had COVID still has the virus in their body. The question is where and how well your body is controlling it. Now this of course means that, what's it doing? Is it causing long-term damage? Is it going to reactivate occasionally and cause health issues, as we know happens with many other viruses like Epstein-Barr virus? We're also actually seeing viruses like Epstein-Barr virus, HPV. The presence of SARS-2 is actually causing those viruses to reactivate, which also causes additional symptoms. So viral persistence is appearing more and more likely to be what's actually going on with long COVID in most people. Now there are of course some people who ended up in, for example, ICU with severe COVID. It could have ended up with things like, it's called PICS, post-intensive care syndrome. And it's probably actually a different thing to what we're seeing with long COVID. How common is this? How common is long COVID? That's a really difficult question to answer because it depends on what you're looking for and how you ask. Are you talking about you've got any symptom at all? Do you have to have multiple symptoms? How severe is it? Is it mild? Is it affecting your daily activities, or are you actually bedbound from it? Now, I've met people that, a lot of people when they had acute COVID lost their senses of taste and smell. And I've met people that it hasn't returned after over 2 years, and even longer. That's long COVID. But they'd never considered themselves to have long COVID. So if you'd asked them, do you have long COVID, they would have said no, but they actually do. Have you recovered? Or do you currently have long COVID? Different surveys and instruments that people are using to measure long COVID ask this differently. One of the top experts in studying long COVID in the US, though, he has noticed that everyone who tells him that they've recovered, when he asks a few questions, he realizes they haven't actually recovered. I'll talk about a little bit more about this later, but I had quite severe disabling long COVID for almost 2 years. I consider myself recovered, but I'm not actually. I can't eat beans anymore. This is a problem. I'm a vegetarian and I cannot eat beans. I get severe intestinal distress, heartburn, all these problems. If somebody sneaks beans into a meal and I eat it, I basically get no sleep that night. Did you have confirmed COVID, or do you just think you had COVID? A lot of different studies that ask whether, or try to work out how much long COVID is around, look at that in different ways. Is there a control group? Like, do you ask a group of people that didn't think they had COVID and a group of people who think they had long COVID, have you been tired the last few weeks? Well, everybody felt tired sometime in the last few weeks, so you ending up with a very small percentage of people who report long COVID when you subtract the two figures there. That's problematic. Most places have actually stopped researching prevalence of long COVID. We don't want to hear about it. We don't want to know about it. The US is still running what's called the Household Pulse Survey. It's been running for many, many years prior to COVID. Their most recent data report that 17.6% of people who believe they've had COVID report they're still having symptoms or have ever had ongoing symptoms for 3 months. 6.8% currently have long COVID. This is data from a few weeks ago. So you can see January to February this year was the survey. 5% their activity is being limited, and 1.5% significant activity limitations. Now those are high percentages, but in real terms, what does that mean? That means nearly 20 million people in the United States currently have long COVID. 4 million, it's severely affecting their lives. That's a lot of people. We can expect it to be much higher here in Europe because, obviously, larger population. So by the end of 2022, it was estimated that between 200 and 400 million people worldwide had experienced health issues, long-term health issues from COVID. That was the end of 2022. Then we let Omicron go wild, and many, many more people have been infected. You can affect, I expect it's probably over 1 billion easily. Now, if we're seeing this, people often ask me, well, if this many people were being sick from this thing, we'd be seeing it. Well, you wouldn't necessarily. If you'd lost 10 or 15% of your lung function and you weren't an athlete or someone trained regularly, you probably wouldn't notice, right? Athletes, on the other hand, have noticed, and there's a lot of athletes reported actually having to retire from professional sport and Olympic level sport because of what's clearly long COVID. But let's have a look on other potential factors. This is in May of 2022, so nearly 2 years ago. Falling participation in the labour market is not a lack of job opportunities, but a rise in long-term sickness linked to the pandemic. The issue of long COVID is very serious. This wasn't doctors saying this or epidemiologists saying this. This was economists from the Bank of England wondering what was going on with the recessions. And latest data now out of the United Kingdom, you can see on the right-hand side of that graph there, long-term sickness has been increasing dramatically. There's a lot of people out of the workforce. You're not quite seeing the same impact in the United States, but when you actually break down the data, you discover that they've had a huge increase of employment amongst new immigrants, where it hasn't happened amongst native-born Americans. So it's the immigrants are coming in and filling up the jobs. Here, closer to home, in Germany, I saw a report recently saying that the recession in Germany can actually be tracked to long COVID. That without long COVID, there would have been growth. With long COVID, it put the country in a recession. With more than 20 sick days a year for the average worker. When I was putting this together this morning, literally, I discovered the same report came out a year ago. 2022 data showed that the people were having, on average, 12 days of sick leave a year, and you can see compared to the average before COVID. Yeah, study, record sick leave led to recession. Now, in Sweden, we're also hearing it in schools, and we're seeing this the same in the UK, alarm from inside the schools. This is translated. Rampant after the pandemic. What's rampant? School absences. Now they're trying to blame it on lockdowns. Now, it's not quite true, but the lower schools and middle schools in Sweden were operating to a certain level throughout the pandemic. VAB, that's vård av barn, or healthcare for children. In Sweden, if you're a parent, you can get paid days off at 80% to look after sick children. Oh no, they're complaining that way more parents are taking VAB. Now they're trying to say, oh, they got used to kids being home during the pandemic. But it's not. Kids are actually sick. The United States, there was a paper written by David Cutler and Larry Summers, who was formerly Secretary of the Treasury, I believe, economists. David Cutler had to update it a year later, and he estimated the 5-year cost of long COVID has been $3.7 trillion US in the United States. That's an enormous impact. Now, personal story. I was infected in wave 1 of the pandemic. I'd actually had visitors from southern Austria and a Malaysian guy who came to me from China, where he'd visited Wuhan. And I fell sick the beginning of March, right at the beginning of the pandemic. It was fairly mild. I kind of recovered, and then I started to get back into training. I was seriously training karate at the time and training towards my black belt. And I was on about the 3rd time I was jogging, and I almost collapsed. I just could not breathe. Then for the next 2 years, I was up and down. But I basically couldn't work. I had a startup in digital health technology. I had to shut that down. I had to lay off the employees. I couldn't get sickness benefits because nobody knew about long COVID. And of course, I'd come from a startup rather than a job, which complicates things. And for nearly 2 years, I was basically unable to do anything. I can remember once I merely spent some time cleaning the kitchen, and I had a lactic acid build up in my body that was so high, so fast, that I vomited. And I was one of the first people reporting that as a symptom, and now that's a known sign of long COVID. There seems to be some kind of mitochondrial dysfunction. Sadly, it hasn't just been me. These are my two boys, Dominic and Isaac. Dominic turned 18 2 weeks ago. Now, I've been recovered for about 2 years now, apart from the stomach issues I mentioned before. I'm back into training again with karate and living most of my life. Dominic got, actually our whole family got COVID in Christmas 2021 from a friend of Isaac's visited us. He'd been the only person in the house for 2 weeks. And he called us a few days later and said, "Are you guys sick? My grandmother tested positive for COVID and I'm sick too." And then we quickly all got sick. We all got better. Dominic did not. He was in grade 8 at the time. He basically couldn't continue school, and he hasn't been able to since. He's now doing distance education. But he tried to start high school, which he'd been looking forward to for his whole life. He had his whole life planned out. He was going to be joining the military. He went to his new high school and survived 1 day a week for 3 weeks. Going to healthcare, nobody could help him. Nobody could find anything wrong. Same thing happened to me. Nobody could find anything wrong. Thanks to some doctors that have long COVID in Sweden, I gave pressure to his doctor to do some tests. And the doctor rang me up as soon as the test results came in and said, "Take him to the emergency department immediately." He had very high levels of indication of blood clotting going on in his body. And every single time he had blood tests for the next year, they basically called us and said, "Take him to emergency." They were worried he was going to have a stroke as a 17-year-old. He's since been diagnosed because we found a doctor with POTS that I mentioned earlier. His heart rate can go to 180 sitting at his desk. Once his smartwatch went off in the middle of the night and woke him up because it warned him his heart rate was too low. It had dropped under 30. Before he got on the medicine, his feet would go blue to black when he stands up because all the blood would rush to his feet because his body is not controlling his blood pressure properly. Now, Isaac has mostly been well, but we just noticed he keeps getting sick all of the time. And a lot of parents are reporting this. And a few days ago, I actually logged into the school software and checked his attendance since he started at the school. You can see the pandemic started halfway through grade 4. This is how often he's been off school. The last 3 years, he's averaged 40% of school days he's missed because he's been homesick. So, where's this going to go? Right. A couple of years ago, I wondered, well, if you roll a dice, if you roll it once, you've got 1 in 6 chance of getting a 6. But if you keep rolling the dice, sooner or later, you're going to get a 6. So I did some simple mathematics on cumulative risk, like how likely are you going to get a 6 if you roll the dice 10 times? Well, how likely are you going to get long COVID if the risk is the same every time you get infected? Now, we don't know, is the risk the same? Maybe after you've had it once or been infected once, the risk goes down. Maybe the virus causes damage and the risk goes up. We didn't know, not when I did this graph, and it was very, very controversial when I did it. At that time, the CDC estimate was that around 20% of people who got COVID got some form of long COVID. So there's no serious level there. But you can see on that estimate that on the CDC estimate, after about 4 or 5 infections, the odds that you're going to have some form of long COVID, so you're sick for at least 3 months, actually exceeds 50%. Recently, Canada did some data, the first one I'd seen, where they actually looked at what's your risk of ever having a long COVID, depending on how many times you've had COVID confirmed. And this was the result. You can see 1 infection, they came up with a 14.6% risk using their definition. To 2 infections and 3 infections, it went up and up. So how does that look? Well, I took that 14.6% risk, plugged it into my cumulative risk graph. That's the green line. And the orange dots are what they actually found. It almost matches exactly. There's no way in the world it's going to stay that way. Statistics doesn't stay that way. But it certainly indicates that the risk of getting long COVID is probably fairly similar every time you get COVID. Now, here's our problem. How often do people get COVID? Often people talk about COVID like the flu. Well, people get a thing called kind of like long flu. We know that happens, okay? The problem is people get the flu about once every 5 years or so. We often say we've got the flu, but we've got some other virus. This is data from the US, but I've seen similar data in Sweden that on average, since society opened up, people are getting COVID at least twice a year. Okay, so compare that to the flu of once every 5 years. This is from a colleague in Canada. They looked at, well, how many people are going to end up with long COVID, either from disabling long COVID, ongoing long COVID, or ever had long COVID over the next few years. And by 2026, you're looking at 1.2 million Canadians, it's a very similar population of Poland, are going to basically be disabled, unable to work because of long COVID. And nearly 10 million, over 9 million people will have had significant illness. So what can we do about it? Hopefully I've concerned you a little bit now. Well, I like to talk about what I call a Jon Snow moment. Not that Jon Snow. That Jon Snow. Jon Snow was considered the father of epidemiology. He noticed that everybody getting cholera in London, this back in the 1800s, seemed to be very close to a particular water pump. At that time, people believed disease came out of a thing called the miasma. They didn't know about germ theory. But he figured there's got to be something going on with this water pump, and he tried to get them to shut down the water pump to stop the cholera outbreak. He failed, but eventually it did happen, and the outbreak went away, and we now know cholera is a waterborne disease. And we reacted to findings like that. This is actually from Chicago, where they literally raised buildings to improve the conditions of water, of both sewage, water provision, and still water. They were having problems with typhoid, they were having problems with cholera, all sorts of things. So millions of dollars were spent to basically ensure that waterborne diseases were no longer killing us. Now, we now clean our water to rid ourselves of these waterborne diseases. We are not cleaning our air. And what can you do? Ventilation. You probably may have noticed I've wandered around opening windows a few times today. Filters. There's a filter there, a filter there. There's another one at the back. These filters, they're only like a couple of €100, I think. They actually remove the virus out of the air. Indoor air quality monitoring. You can actually monitor the quality of your air using carbon dioxide buildup as a proxy for how much potential virus may be in the air. And I've been checking that around the room here today too. Far UVC is a new technology. There's ultraviolet light that will disinfect the air without damaging our skin. Masks, obviously. Masks work, okay? Don't listen to the bullshit, they don't work. They're a pain in the ass, I entirely agree. And I do my own kind of risks assessment. So I have a mask here, but I've checked and COVID is very, very low in Europe at the moment. You'll notice I was sitting over here near doorways or near the air filters. I wasn't sitting amongst everybody else. I was making sure doors were open and I was monitoring the air quality. Vaccination also appears to lower risk of long COVID by up to 50%. We don't know how long that lasts. Similarly, does having an infection protect you from getting long COVID if you get infected again soon? We don't know. The Canada data indicates not. Now, interestingly enough, there was a big push in Europe 2008 to 2013 on indoor air quality. They did a very, very large report on it. They did not mention pathogens, viruses, once in there. They were really talking about pollution and these type of issues. But they actually say that every European citizen has the right to indoor air quality that does not endanger their health. We now know that a lot of viruses, including COVID, are in the air. We can clean them. Ventilation is one of the ways. And the interesting thing is, there's already laws on this. This is from Australia. Mechanical ventilation, this is the building code for commercial buildings and public buildings. They must control the accumulation of harmful contamination by microorganisms, pathogens, and toxins. Somebody said earlier about we don't need new regulations, we just need the governments to act on them. It's the same with this. We actually have this in our laws that we should be cleaning the air so that people don't get sick. CO2 monitoring. This is a little device I have here. Right now, 700. That's okay. 4,300 is what it was on the plane coming down. I had my mask on then. This gives you an idea just on the health effects of CO2. So 2,000 to 5,000, headaches, sleepiness, stagnant style life, poor concentration, loss of attention, increased heart rate, and slight nausea may be present. I really hope they had better air for the pilots than we had back in the plane. In the UK, they did an experiment. They gave HEPA filters into schools, and it cut sick days due to COVID by 20%. Masking, I use it in high-risk situations, if it's crowded lots of places and people. But if we do the other things, we don't have to worry about masking except in those high-risk situations, because nobody likes masks. And you've got to do your own risk assessment. I go home to people who have to go to school every day and get infected. He's got less than 1% chance of getting infected if there's somebody here with COVID today. So, by cleaning the air we breathe, we can not only get rid of COVID-19, we can affect all airborne diseases. And a little known fact is there are 2 strains of influenza that are gone because of the things we did during the pandemic. We've eradicated them, and we didn't even try. That was by accident. Thank you.
Thank you, David. Now I will ask Vicky van der Togt to join us. Vicky, are you with us? Because we are not.
Yes, I am with you. Can you hear me?
Oh, yes, and we can see you. Hello.
Yeah, hi everyone. My name is Vicky van der Togt. I'm a former long COVID patient, a patient advocate, and also a patient-led researcher from the Netherlands. I also work as a director of development at the non-profit organization Research Aid Networks and as an expert advisor for the UK-based patient charity Long COVID SOS. I was supposed to be there in person today, but unfortunately I was hit with some odd allergic reaction and have been put on medication and told not to travel. And so unfortunately I'm not there with you today, but thank you for letting me still give my talk, but then virtually. Like I said, I'm a former long COVID patient, and I turned to patient advocacy as no one else was talking about this disease and these long-term symptoms in my country back in 2020. And by speaking out online, I quickly connected with other patients from around the world and eventually worked hard to connect long COVID groups from around the world over the course of the last 4 years. And therefore, I was asked to speak today about the international long COVID community, how it came to be, what patients need, and what they need you to know. So let me just get to it. In 2020, during the first wave of the pandemic, there were many people, including me, who got sick with COVID-19 and didn't recover. And fairly quickly, patients from around the world were noticing that, unlike what the government and health authorities were saying, they didn't seem to recover from their illness. And they started speaking out online on social media platforms, often because that was the only type of communication that they still had. They weren't able to leave the house, they weren't able to socialize, they were simply too sick to do so. And so having these online opportunities really gave them a way to still connect with people. As David already mentioned just now, Elisa Perego, an Italian patient, spoke out about her ongoing symptoms fairly early on in 2020. And she coined the term long COVID in May. Thereby, she made visible the persistence and heterogeneity of the COVID-19 symptoms, as well as that she gave patients a term to use for their ongoing symptoms. Now, more and more patients from around the world started speaking out about these symptoms, and they started forming patient groups and patient support groups to help and support each other, as there was very little help available for them, and they scrambled to really understand more about their disease and how to get the care that they needed. Many reported that healthcare professionals weren't able to do much for them, and oftentimes their symptoms were even dismissed. Patient organizations did get the attention from the World Health Organization, who decided in August 2020 to set up a meeting with patient advocates from around the world to get a better idea of their struggles and see what they could do to help. Fortunately, the World Health Organization did take their message seriously, and they were very eager to raise awareness for these ongoing symptoms of COVID-19 infection. But unfortunately, not many have followed suit. And that type of messaging from governments and health authorities from around the world is still lacking today. So since 2020, patient advocates have been fighting hard to get their needs heard. So what do patients need? Well, Long COVID SOS, the organization that I'm representing today, has three key aspects that they fight for, which is recognition, research, and rehabilitation. It's also their tagline. And I find that a good start, so let's start with recognition. Patients want governments and health authorities to acknowledge that COVID-19 has a wide array of long-term consequences and that these outcomes differ from person to person and in disease severity. Preferably, they would like their governments to actively educate the public on this. It is important that the public knows that COVID infection can have many adverse outcomes, including cardiovascular, thrombotic, cerebrovascular disease, diabetes, myalgic encephalomyelitis, or dysautonomia. But next up is rehabilitation, which of course is an important one. This is a difficult one because of the broad range of symptoms of long COVID. Those who only have a few symptoms may be able to be helped with physiotherapy, while this can have dramatic worsening of symptoms as a result for those who have ME/CFS type symptoms. There is little medical education on this, which leads to a situation where patients find it hard to find the care that they need. Oftentimes, doctors are also misinformed on the disease, and thus patients can get forced into rehabilitation programs that are unhelpful at best, but that can also have severely damaging consequences. This lack of education on the disease made for a situation where in many countries, patients have had to take it upon themselves to inform their general practitioners and other medical professionals about certain aspects of the disease. This was a struggle back in 2020, but unfortunately, it's still a struggle to this day. So patients, they struggle to get a diagnosis. Oftentimes, they struggle with being taken seriously, and overall, they still struggle with being seen in general. It needs to be said that there's currently no approved treatment or medication available for long COVID, but there are medications out there that can help manage symptoms, while I and many other researchers from around the world look for treatment options that work. And it's important that these medications are made available to patients as they have the potential to dramatically improve their quality of life, even if it isn't a cure for them. But next, I want to talk to you about ongoing risks. There really is a need to talk about the occupational risks and the financial aspects of COVID. Simply put, you can only get long COVID if you get COVID. And it needs to be said, especially in 2020, that there have been many essential workers who were ordered to keep working, sometimes despite being sick, often without any protective equipment, and many of them contracted the disease and subsequently developed long COVID. Now, many of these patients weren't able to get back to work. They had to reduce their hours with all the consequences of that, also financial consequences. And this resulted in that many patients struggled to survive, both physically as well as financially. Many countries don't have proper sick pay schemes in place, which makes it impossible for patients to stay afloat. Sick pay often also isn't enough to live off of for a long amount of time, and many struggle with obtaining disability status. And unfortunately, there is still an ongoing risk of COVID-19 infection. It's still going around, and little is done to prevent infections. And the result of this is that there's this ever-growing amount of people that are out of the workspace, and that this number will only grow with time. However, we know what can help to lower disease transmission. David Steadson just mentioned a whole range of preventative measures that can be implemented that would dramatically lower the amount of transmission. And all these measures should definitely be implemented in the workspace, but not just in the workspace. There's also a real need to implement these in public spaces as well as in schools. because long COVID doesn't just affect adults, it also affects kids. And this is not nearly talked about enough. But yes, children can get long COVID, and we must do what we can to keep them safe and to make schools safe for them. Now, some of these measures, like I said, David already mentioned them, but installing HEPA air filtration, ventilation, having CO2 monitoring in place, as well as keeping proper isolation, testing, and masking rules in place for if there are active infections are still good things to implement. By doing so, we can not just protect the health of the children, but also their teachers and other school personnel. Aside from this, I'd like to touch on the situation in hospitals, which is a big issue for many in the long COVID community. It is being reported more and more that masks are not even worn in hospitals anymore, and thereby this creates an unsafe environment for the most vulnerable who are in need of care. Protective equipment must be worn around long COVID patients or around COVID patients to prevent further disease transmission to medical personnel and other patients. Unfortunately, we hear more and more of patients who go into the hospital for a non-COVID emergency, but end up contracting the disease in the hospital, sometimes with the most dramatic consequences. Of course, this can all be prevented, and I personally can only say that I think it's a very logical step to at least have masking in place in hospitals. In 2021, I've helped a large group of healthcare workers in the Netherlands take the first steps to try to get compensated for not being provided with adequate protective equipment or the correct information about COVID transmission. This caused them to catch COVID at work, and they subsequently developed long COVID. Recently, and I'm really happy to be able to say this, these actions have led to a victory for them. And every healthcare worker that developed long COVID due to insufficient government handling in 2020 got compensated. They each got 15,000 euros, and there's been a specific fund set aside to compensate them of 30 million. I'm incredibly happy. Of course, they deserve this compensation. 15,000. It's a nice sum of money, but it's still rather small if you keep in mind that they have lost their livelihoods and they don't even know if they will ever be able to get back to work. Currently, a group of healthcare workers from the UK is taking steps to get compensated as well. And it needs to be said that both groups state that they followed government guidelines, but that those guidelines fell short in their supposed goal of protecting them or their patients. Now, the total cost of COVID, both economically as well as the legal action like this, it only further adds to the enormous cost of long COVID. And when looking at this overall cost, it's plain to see that the suggested investments to lower disease transmission will easily pay itself back. Now, I spoke to the European Commissioner for Jobs and Social Rights, Nicholas Smith, in 2021 about all these aspects of long COVID and gave a list of what patients need. But unfortunately, many of the struggles mentioned back then still exist to this day. And so it's time that we listen to patients. They deserve to be listened to. They deserve to get the care that they need. They deserve to get the support that they need, and they deserve to be compensated for being put in unsafe situations that cause them to become sick and sometimes even fully disabled. They and the general public deserve to be protected from further harm, and this means people need to be given correct and clear information about the disease and how to prevent it. Now, aside from all these obvious points, patients around the world call for more research funding to be made available to search for a treatment for this debilitating disease. Some even say that we need a long COVID moonshot, and I have to say I agree with them. I hope you all in attendance will work with me and the organizing partners to make this all a reality. Thank you for having me today.
Thank you. Okay. I would like to break with the tradition, and I have a question. Something like a question or comment, something like call to action, because of course COVID is a political annoyance, and not only political, it's a social annoyance. But as we have heard, it's not possible to just move on without addressing question of the air quality. And it's difficult to talk with politicians either on the right or on the left, even in social democracy, about these things, because of course there is a huge political risks about it, but not only risk in my opinion, but risk and political chances as well of addressing it. And so I have a question for our political guests and partners. What can we do to address this need for Jon Snow moment? Yes, and David spoke about it. So I don't know. I'm sorry, maybe it was too direct, but okay, maybe let's keep it in there.
Yeah, it's well, I'll just
Yes, it would be good now, to raise those questions to European Commission, and of course, keeping in mind healthy workplaces. The healthy workplaces are very strong regulatory frame, which is just brought a lot of attention, and it would be good to now. To raise those questions about situation, how can we improve working places, especially because now it is up to new commission, up to new mandate to draw attention and to push forward all, to provide a report, to recommendations, to ask council to build some council conclusions, and then to encourage member states' governments to see how they are addressing issues related to healthy workplaces, especially keeping in mind air pollution. Now air pollution is generally a very high topic. We pressed very much about environmental component. Environmental health now are closely interrelated. But environment means air quality. Air quality means, possibilities to monitor, to see, and to introduce necessary measures, especially keeping in mind, some places where people are working very intensive. I think that now is a very good time to raise those questions openly in front of European Parliament elections, and then speaking about new mandate of European Commission.
I'd just actually like to add something to that, because one of the things that's been happening in terms of building codes the last few years is the green movement, energy efficiency. And this has actually worked a little against health, because now we're blocking all the ventilation because we're trying to keep the heat in or keep the heat out. But there's already this movement of healthy buildings, which is taking into account both being energy efficient and looking at pollution factors. So all we're needing to really do is just add in one extra thing here. How about we look at pathogens as well as viruses and bacteria?
When COVID started, I was a big fan to propose a lot of measures drawing attention on ventilation, on CO2 measurement, on possibilities to introduce, ventilation systems, control, and so on and so on. Now we still to do the same. We need to continue. We need to press, because it is obvious. Obvious. We need to keep it, not to say okay. Now it's not a pandemic is over. We need to draw attention on other issues. No, we can especially keeping in mind evidence keeping in mind evidence. Long COVID is based on evidence. We need to now to collect much more evidence and then present once again, recommendations. What can we do? When we can do? How can we do? Because now it's permanent issue. You have no chance to be not active in this field.
Hello, good afternoon. My name is Mihai Kökény from Hungary, also a former politician, and you addressed, the question, how the politicians are thinking it's about. I think it's really an opportunity for various reasons, and we have heard that we still don't know enough. There is a lot of unrecognized, unmapped areas, So I think that, what we know and what we do not know about the long COVID and its impact on various sectoral matters, policies, labor, on health, on housing, on environment, or whatever you would learn. That's really, I think, a good reason to advocate for putting health higher on the EU decision-making system, Because, as you know, neither in the Parliament nor, in the Commission, I would say health is there, but not as an independent portfolio. And then there's probably an opportunity that why we need to change. But I finish here because time's up.
If I may raise one question about vaccination, because now the uptake of vaccination now is going down, down, down once again. And we need once again to encourage, governments to draw attention on possibilities, especially speaking about vulnerables, especially speaking about those people who are at risk, to continue vaccination. It would be now, it's timely, once again, to discuss about permanent vaccine programs, keeping in mind this long COVID syndrome.
We need to finish, but please, Vicky.
Hi, could I respond? I agree with that last sentiment, which is that there's a real need to repair trust in authorities, in health authorities specifically, as well as governments. There's a lot of trust broken, as well as a lot of misinformation that is still going around on vaccinations that is having dramatic consequences. And we see that now, for example, with other diseases going around that we haven't seen going around this rampantly for a long time. I did want to add one thing, which is that what we often hear as patients is that there is very little known about this disease. But when you really look at the research side of things, this is actually one of the most well-researched diseases out there now. I personally, with my organization, we keep a research library, and we have a vetted library, which means that a lot of them don't even end up in the library. But our research library already consists of over 2,700 research papers into long COVID. But I know other libraries that have over 5,000. And so we cannot say at this point that we don't know enough. Now, with that same sentiment, it also needs to be said that we also keep a research library into the efficacy of masks, as well as the effectiveness of air filtration in filtering pathogens from the air. And so with this, I just want to say that the research is out there. It's just time that we actually implement it.
Okay, thank you for this discussion. Thank you